So you have to be very cautious. Make sure the stain is properly, the sections or smears are properly stained, and you go to an area where you can beautifully see the cells in as a single dispersed film, and then make a call. So next, with this in the background, I thought I will introduce you all to the astrocytoma. So all this is required. Until now, you have not even started to see, you have not come to the microscope, you have not even seen the histopathology slides. Now you are going to get a histopathology slides. Okay, so I start with astrocytomas. I have tried to complete astrocytomas only today, and last two cases have been two interesting cases to show how we work them up. Okay, so typically we see diffuse gliomas are gliomas are of two types, circumscribed and they are diffuse gliomas. I don't know, something is wrong with the slide here, it is not showing properly. Okay, so how do we grade astrocytomas? When only ATP is present, it becomes grade 2. Mitosis adds up, it goes to grade 3. And if there's endovascular proliferation necrosis, then it becomes grade 4. All this is set to change now in the new WHO. But for now, it is sufficient for you beginners and the young young pathologists who are dealing with neuro cases to remember AMEN criteria: ATPia, M for mitosis, E for endothelial proliferation, and N for necrosis. Okay, so whenever you see endothelial proliferation necrosis, you have to think it is a high grade glioma, probably grade 4. Okay, now there is astrocytoma grade 4 entity is also creeping up into the new WHO, but only ATPia cells are there. ATPia is only required. You don't have to have any additional things to fall grade 2. Grade 2 only ATPia is just enough to call it as a glioma grade 2. Mitosis, when they add, it becomes anaplastic. Many people equate these anaplastic features are and anaplastic features are. I always resist the temptation just based on ATPia, marked ATPia of the cells, to call them as anaplastic, because mitosis are my friends. Mitosis are neuropathology friends. Okay, we have a lot of tumors that can show a lot of ATPia without necessarily being anaplastic. So that is the warning I tell. Please don't use anaplasia as a sole criteria to make a grade 3 diagnosis. You have to have mitosis. For astrocytoma, the number of mitosis is not fixed. In a needle core sample, if I find even one mitosis, I tend to favor an anaplastic grade, because the random chance of getting one mitosis in a diffuse glioma is 1 in 100. Because even when you give me the entire sample, I have to struggle to find one mitosis, two mitosis in a grade 2 glioma. But when even a random chance of a biopsy pulling the mitosis means there must be a lot to present. But I will always give a disclaimer saying that, sir, I am seeing 1 or 2 mitosis, so I am favoring anaplastic grade. Because remember, anaplasia does not have enhancement pattern. Enhancement pattern comes only when endovascular proliferation sets in. Okay, so increased a case can be a high grade glioma without having enhancement. Okay, so necrosis will not produce enhancement. Okay, it's only the endovascular proliferation. So you can have mitosis and necrosis and still be a high grade glioma histopathologically, whereas radiologically it will be a low grade. But that's a different story. Okay, so you can have low grade looking radiologically tumors that are high grade on histology. That conundrum does exist. Okay, and so this is the basic AMEN criteria. You please remember, students who are there, please remember ATPia means grade 2, mitosis adds up is grade 3. For anaplastic oligo, I usually use 6 mitosis as a cutoff in the absence of endovascular proliferation necrosis to call it as anaplastic. Okay, so grade 3. So mitosis sets in, it becomes grade 3, endovascular proliferation or necrosis grade 4. So this is the AMEN criteria. Please remember, in the exam or in the hall or when you are diagnosing the cases, these things will help you to put a tentative grades. Okay. Okay. So what do we do? Diffuse astrocytomas occur in young age. Headache is the most common symptom. They are insidious, slow growing, and they come many a times. Seizures is the last symptom. When it becomes infiltrates into the brain, you start seeing. So seizure is the last later symptom. Headache is the first symptom in diffuse astrocytoma. And here is the imaging of the diffuse astrocytoma. You can see here, this is a coronal slice of a post-contrast image. One is post-contrast, here you can see, and here is the flare sequence here. All right. So you can see the CSFS is dark. Okay, so it is probably a T1 sequence, and you can see the vessels that are highlighted there. You can see there is in the periphery, you can see those bright spots are there. Not a very good picture, but believe me when I tell you. So there is an area of hypodense or hypointensity in the right hand side in the temporal lobe. and compared to the cortex. So this is an area where there is an abnormality on the right hand side. And the same sequence, when you see on the flare, you can see there's a lot of edema around it. The bright areas are representing the tumor with edema. You should remember, when the tumors are low grades, they respect the anatomic boundaries. They just go along the nerve bundles, they infiltrate, but they don't destroy. The overall, the structure of the brain is maintained intact. Okay, so that is why many a times we find it difficult when they go to biopsy. You may not see the tumor or the tumor area very atypical from the normal brain. That is why they search and ask us for frozen. So this was a low grade glioma because it is not showing enhancement, and on flare there is definitely edema causing some kind of a midline shift. If you compare on right hand side, the right side brain tissue is slowly getting pushed towards the left side. Okay, so here is a gross. In the highlighted area is where the tumor is, and I had shown you before. Okay, if you look on the other side, the gray-white junction, the cortical ribbon I call it, is beautifully maintained, gray and white. But when you come to the area that's highlighted, in the circle, you can see there is a blurring of the gray-white junction. So grade 2 astrocytomas, if you have a brain with you, you feel the tumor, you don't see the tumor. Okay, but if it is grade 3, they become mushy, soft, mucoid. You can see it and feel it. So when they're grade 2, they're firm, very compared to the normal brain tissue, and they blur the gray-white junction. This is a low-grade glioma, astrocytoma. On autopsy, it had already crossed, and we could see the tumor on the other side. So grossly also, when you see the tumors grossly, but still when you see microscopically, the tumor had crossed the midline and it had reached the other hemispheres. Although you cannot see in the white matter here, because I told you initially tumors maintain and respect the vascular boundary and the anatomic boundaries. So you don't see much change. Only when it becomes obvious, when it's very cellular, then you start seeing the changes reflecting grossly. Okay. This is a smear preparation here on the left hand side. On the right hand panel, you're seeing beautifully the nuclei and the fine fibrillary process in the background. Astrocytes produce a lot of processes. The smears are very fibrillary. So fibrillary means glial. Okay, fibrillary equates to glial. No fibrillary, either oligo or it may be some other tumors. Okay, so whenever I see a lot of fibrillary process in the background, I think of an astrocytic tumor. This is a low-grade glioma. Diffuse cells is scattered all over the place, very small, bland-looking, irregular, hyperchromatic, and I don't see any mitosis or increased necrosis or endocytic proliferation. Very classic example of a grade 2 astrocytoma. If you go closer, you can see the red and the black arrows. So the black arrows are highlighting the irregular hyperchromasia of the astrocytic tumor cells. Okay, the red arrows are pointing at the neurons. So why are the neurons seen in between the tumor? Because the tumor has infiltrated the cortex. Because cortical region has neurons, so this tumor has invaded the cortex. That means it is an infiltrating tumor and it is a diffuse glioma. We don't see mitosis, and when mitosis adds up, it becomes an anaplastic tumor. Okay, so usually they are positive for glial fibrillary acidic protein. This is the basic, because they produce, by the tumor cells produce this GFAP protein, which we can use it for highlighting. Okay, on the left hand panel, it is a GFAP, glial fibrillary acidic protein, and the tumor cells in the center, many of them you are seeing, the nuclei is blue, and the around it you see the brown structure, that is the brown color, that is the positive cell. Cytoplasm is positive. If you look at the upper hand side, see now things have changed. When 2016 changed the whole classification of the astrocytomas. Now they made it IDH positive and IDH wild type, IDH mutant and IDH wild type. So most of the time grade 2, grade 3 gliomas tend to be IDH1 positive, and they show loss of nuclear expression for ATRX. So these are the two combination markers we use to assess. All tumors, astrocytomas that are IDH positive, typically 9 out of 10 chances are they show loss of ATRX expression, because that is how the tumors arise. They use this ATRX pathway and there is loss of expression either by mutation or loss of function gene. Okay, so when IDH comes positive, ATRX is lost, GFAP positive, and one more marker most often we see is the P53. P53 comes diffuse and strongly positive. The brown dots you are seeing in the left hand panel are all the nuclei that are positive for P53 antibody. And to call a tumor as P53 positive, Diffuse strong positivities should be expected. Although I use anything more than 20% with strong positivity, I would tend to call it as a positive slide. Okay, so P53 positivity, ATRX loss, IDH1 positive, you are looking at a grade 2 or a grade 3 glioma. For grading, you don't need IDH. Okay, but for classifying it into a good and a bad type, you need a IDH. IDH and positive tumors usually have a very good prognosis. They behave very well. Now that is also changing in the new WHO, but for now you just remember that IDH positive cases means that's a good glioma to have. They have a long outcomes. Okay, then neurofilament, most often I use it to assess the infiltrating quality. Tumors that expand or push the tracts aside are usually expansile growing tumors, pilocytics, and you can see PXAs, gangliogliomas. These are all non-infiltrating gliomas. But when it is diffuse glioma, they do infiltrate, they do destroy the axons, and the axons are highlighted by neurofilament protein stain. Okay, and you can see them as the squiggly linear structures that are brown in color. Those are the disrupted axons by the tumor. The tumor cells are negative because they're astrocytic. Neurofilament is the axonal stain, so it is staining the axons. So the tumor cells will be negative, the axons will be positive, showing the fragmentation and telling us that these are infiltrating gliomas. Okay, so now in infiltrating gliomas, now all these years we have seen there are tumors that occur in brainstem. Again, I told you it's a real estate brainstem, high priced location brainstem. Okay, anything happens there which goes downhill very quickly because of the space, the way it is located, and there's not much space room. But now in the previous WHO, which 2016, came up with a new entity called as brainstem glioma midline. Okay, they can have histomorphologically they are low grade, but they have a genetic abnormality involving the histone genes. Okay, which is called as H3K27M. So you usually, when you know we are dealing in the midline, right from the thalamus, brainstem, pons, medulla, anywhere they can occur. Okay, whenever you have tumors localized to these regions, they can be not enhancing or non-enhancing. They can be very low grade looking, but we always end up doing one marker that is called as H3K27M antibodies there. Now we do that test, and if it is a mutant, that means there will be a lot of mutant protein in the nucleus, and it will be highlighted. On the left hand panel, you can see all the brown dots are nuclei showing the aberrant expression of H3K7 mutant protein. Okay, so this is the H3K7 positive glioma, and they occasionally can, there is one more counter stain which is complementary. What we have, when there is loss of or mutations of H3K7M gene, they show there is loss of trimethylation. Okay, this is the product that is controlled by the H3K7M gene, so it will be lost. Okay, and there are other ways also how you can see the loss of H3K7 trimethylated residue, we call it as. It can be lost by other pathways also, but for now you can remember that H3K7M positive tumors must and should show loss of H3K27Me3 protein. Okay, only then you can call it as a H3K27 altered midline glioma, WHO grade 4. This is one of the tumors where the molecular findings decide the grade and not endovascular proliferation or necrosis. This tumor, it is our own case from here. We did not have any areas of necrosis or endovascular proliferation, but we did see mitotic figures, and we had called it as anaplastic grade, but we had already warned that it's a may turn out as a midline glioma, and lo and behold, it came out as a H3K27M mutant glioma, and patient died within a week. 16-year-old girl, family full of doctors, only daughter came with this. Very rapid onset. Very sad story. I did a frozen at night at 10 o'clock because they had come. It was an emergency situation. So we did frozen at night 10 o'clock, and we had rendered the diagnosis. I had suspected all along that this is going to turn out to be a H3K27, and lo and behold, it did.